Hi everyone, my name is Matt and I'm going to be presenting on EKGs in the Syncope patient. I wanted this presentation to really address some of the weaknesses I have, and I realized that syncope is actually one of the hardest chief complaints I've noticed in the ER for myself. And EKGs, I feel like I'm getting better at spotting STEMIs, but some of the more nuanced changes are a little bit hard for me. So we're going to address those head on. First, I'm going to say I'm looking at specific findings in specific pathologies. So, although I'm not going to do it for the sake of time, you should always read your EKGs looking at the rate, the rhythm. Is a P before every QRS? Is there a QRS after every P? Look at the axis to make sure it's normal. Look at your PR intervals and your QRS intervals. And then also if you see any signs of any ST elevations or anything like that. Alright, so would you get an EKG in this patient? This is a 25-year-old woman presenting after a single episode during her choir practice at 2 p.m. She states that she was standing for 2 hours, didn't eat all day, and reports feeling weak in her knees, lightheaded, and had this decreased peripheral vision, this tunnel vision, moments before she passed out. Would you still get an EKG? Well, even though this looks like a pretty obvious reflex or vasovagal syncope, it's our job to rule out the scary stuff, and an EKG is a must-do test in any syncope patient. Other diagnostic tests like labs or imaging can be obtained based on your history and physical, but EKGs, they're cheap, they're non-invasive, and they're very fast, and they're great at ruling out the scary stuff. So when I was researching for this presentation, I actually came across this great mnemonic. It's called Wobbler, and it's nice because, in a syncopal patient, they tend to be pretty wobbly. First, of course, we have to rule out any ischemia or dysrhythmia, but then we can use this mnemonic to look at the more nuanced abnormalities. The mnemonic goes WPW, any obstructive AV pathways like heart blocks, bifascicular block, Brugada syndrome, left ventricular hypertrophy. In this presentation, we're going to go over HOCM, epsilon waves, and repolarization abnormalities like long and short QT. For the sake of time, we're not going to be doing the bifascicular block, and we're not going to be doing the repolarization abnormalities. I really picked the other ones just because I feel like they're more common and also more testable, and for us med students, I feel like that's an important thing. So, WPW. WPW is caused by a secondary electrical pathway between the atrium and the ventricles here, called the bundle of Kent. This pathway is actually faster than the AV node, and it causes early excitation of our ventricles. And because our ventricles are excited earlier, we get this shortened PR interval, and we also get this slurred upstroke of the QRS called a delta wave. Of note that this pathway doesn't just have to go forwards, it can be a return signal and cause a circular conduction, causing AVRT, which is a very dangerous, very fast tachycardia. So, what are the findings on the EKG? Well, we have this slurred upstroke, this delta wave, and if I blow up one of the complexes, we can see that we have this short PR interval, which is less than 3 small boxes, or less than 120 milliseconds. Remember, 1 small box is 40 milliseconds. Alright, now we have our obstructed AV pathways. This is our first, second, and third degree heart blocks. Our first degree heart block is a prolonged PR interval that's greater than 200 milliseconds, so 5 small boxes or 1 big box. And then our second degree of a Mobitz type 1, which is a progressive lengthening of the PR interval until a QRS is eventually dropped. And then a type 2, which there is no lengthening of the PR, but a QRS is dropped all of a sudden. And you can have a pattern of the QRS dropping. For example, like a 2-to-1 ratio, you'll have a QRS dropped every other P wave. And then finally our third degree, which has no relationship between the P waves and the QRS complexes. So, this is our first degree block, and as you can see, our PR interval is much longer than 5 small boxes. But we have a QRS after every P, and we have a P wave before every QRS. And these are our second degree AV blocks, and I want you to tell me which one is type 1 and which one is type 2. So the top one, we have this progressive lengthening of our PR interval, and then a dropped QRS, and then we return to our normal PR length. So this would be a type 1, a Mobitz type 1. This one on the bottom, our PR doesn't change, but then we have a dropped QRS and then a return to our normal PR interval, right? So this is a Mobus type 2. Finally, we have our third degree AV block, and I want you to watch. Look at these P waves. They have an equal length, and they don't change in their interval. And our QRS complexes also don't change in their length. So we have a regular rate for both our P waves and our QRS complexes. It just looks like they don't communicate at all. And this makes sense because a third degree AV block means a complete atrium and ventricular dissociation. All right, now we have Brugada syndrome. Brugada syndrome is a genetic channelopathy caused by abnormal cardiac action potentials. This is because of the sodium channels in the heart. This predisposes patients to a polymorphic VTAC or VFib. However, the exact mechanism of how this happens is actually not known. But what we need to know in the ER is that these attacks are most common at rest or when sleeping, and the majority of patients are actually asymptomatic, but they can present with chest pain, syncope, shortness of breath, or even sudden death. However, Brugada pattern can be seen on an EKG, but in order to be called Brugada syndrome, you need to also have a clinical indication for Brugada syndrome. This can be like a documented ventricular arrhythmia, a positive family history, or even just a history in the patient of syncope. So Brugada syndrome on the EKGs, you're looking at V1, V2, and V3. In at least 2 out of those 3 leads, you can have a type 1 Brugada pattern in which you have 2 millimeter ST elevations, a downsloping ST segment, and an inverted T wave. In a type 2, you still get these 2 millimeter ST elevations, but it has this saddleback appearance, and the T waves are either upright or biphasic. Type 3 looks exactly like type 1 and type 2, but the ST elevations are less than 2 millimeters. However, Brugada syndrome is not always present on EKGs. They often reveal themselves when the patient is under a different stress. Maybe they are infected with something, they're using cocaine, alcohol, or even beta blockers can make this pattern show up on EKG. So here's our type 1, right? Here's our J point. We have way greater than 2 millimeter ST elevations, downsloping ST segment, and an inverted T wave. This is our type 2, J point, greater than 2 millimeter ST elevations, and we have this saddleback appearance right here, and an upright T wave. And here, type 3, you can see these morphologies are identical to the type 1, type 2, but the ST elevations are less than 2 millimeters. All right, so which pattern is this EKG? And what I wanted you guys to spot, of course, go through, rate, rhythm, axis, whatever, but really, we can see these coved ST elevations greater than 2 millimeters, this downsloping ST segment, and these inverted T waves. And so this is a type 1 Brugada syndrome. Now, what about HOCM? HOCM is hypertrophic cardiomyopathy, and it's a genetic disorder which is usually autosomal dominant and has a high prevalence. So that means that family history is going to be your best friend in these patients. This is the most common cause of sudden cardiac death in young patients, and it usually comes when they're exerting themselves. They can present with chest pain, shortness of breath, syncope, or even, unfortunately, sudden cardiac death. Here's the septal variant, so you have a thickened ventricular septum. However, you can also have an apical variant, even though that's less common. So spotting HOCM on the EKG, first you have to look for signs of left ventricular hypertrophy, which is the high QRS voltage, and we could use the Sokolov-Lyon criteria, which shows that the voltage of S in V1 plus the voltage of the R wave in V5 or V6, whichever one you choose, the biggest one, is greater than 35 millimeters. And then you can also spot these deep dagger Q waves, which are less than 40 milliseconds in the lateral and inferior leads. You can also differentiate between septal and apical variants of HOCM because the apical variant has these deeply inverted T waves in the precordial leads. But, for the sake of this presentation, we won't go any deeper than that. So here, first, let's look at left ventricular hypertrophy. And so, remember QRS wave of V1, and then QR wave of V5 or V6, choose the bigger one, and it has to be greater than 35 millimeters. So 5, 10, let's call that 15, 20, 25, 30, 35, 40. So we meet criteria for left ventricular hypertrophy, and we also have these dagger Q waves. You can see it in 1, V5, and V6. And I really want you to differentiate between these Q waves and the Q waves you see in old STEMIs, which are pathological, but they're wide Q waves, unlike these sharp ones seen in Hokum. And finally, we have our epsilon waves. This is our last one. Epsilon waves are seen in arrhythmogenic right ventricular dysplasia. This is another genetic abnormality which causes a fatty infiltration of the myocardium in the right ventricle. This causes, of course, we know that fatty tissue is going to be more of an insulator and less conductive than our normal myocardium. And so we're going to get a slow depolarization of the right ventricle, causing this epsilon wave. We can also see a widened QRS and often an inverted T wave. However, up to 50% of these EKGs are normal, so just because you see a normal EKG doesn't mean you can rule out ARVD. And so here we can see these epsilon waves, we can see this widened QRS complex, and we can see these inverted T waves. And so here are my references. I know we went through a lot of content really quickly. So if you have any questions, please shoot me an email. I can send you some great videos I watched and some great articles I read as well.